Hola a todos, hola a todas, ¿cómo están? Espero que muy bien. Bienvenidos a una nueva charla de nuestra carrera Kinesiología UC. Espero que estén todos bien por sus casas. Lo primero que siempre pregunto, si me pueden dar algún feedback de cómo se escucha mi audio por, eh, por, su- por sus computadores, sus celulares, etcétera. Y además, gracias, profesor Gustavo, nos dice que se escucha muy bien. Además, comentarles o pedirles a ustedes que por favor nos acompañen eh, mencionando desde dónde nos están mirando. Hemos tenido visitas desde todas partes de Chile y también de Latinoamérica, así que dejen ahí sus comentarios desde dónde nos están mirando para así transmitirle a nuestra expositora de hoy sus saludos también. Bien, quiero agradecer principalmente siempre como comenzamos nuestras charlas a nuestros estudiantes de kinesiología que nos permiten llegar a mucho más gente con la difusión de todas nuestras charlas. Ya llevamos más de 30, ya estoy perdiendo la cuenta, tantas charlas que llevamos. Así que, por favor, agradecerles a los estudiantes que están ahora conectados también, lo más probable, después de una jornada de clases que tuvimos hoy día. Así que un saludo para todos ellos. Recordar nuestras redes sociales, nosotros tenemos Instagram, Kinesiología UC, @Kinesiología UC y el Facebook Kinesiología UC también, donde ustedes pueden seguirnos y conocer nuestras redes sociales, conocer nuestras actividades, entrevistas, charlas, etcétera. Así que síganos y dejen su bonito like, como dicen los profesionales del YouTube. Por favor, ahí pueden también visitar la página de Kinesiología UC, donde tenemos información también de nuestros cursos, diplomados, posgrados, etcétera, en la cual ustedes pueden revisar. Estoy mirándolo a todos cómo se están conectando, ya somos más de 60 usuarios de todas partes de Chile y de Latinoamérica. Bienvenidos. Como les decía, y acá en la página también están albergadas todas las charlas. Charlas que hemos transmitido por nuestro exitoso canal de YouTube. Llevamos, como les digo, aproximadamente, aquí tengo el número, el profesor Gustavo me lo actualizó, 37 charlas ya, un número increíble. Dentro de todo lo malo que ha sido la pandemia, lo bueno es que ha permitido generar increíble cantidad de contenido para ustedes, gratuito, y que de alguna otra forma nos ha mantenido conectados. Así que los invito a la página de internet y al canal a suscribirse para estar al tanto de todo lo que van a venir. Se van a venir grandes sorpresas para fin de año, así que atentos, ya primera vez que lo digo, pero van a venir algunas sorpresas a fin de año para que estén siguiendo nuestras redes y página de YouTube. Bien, las preguntas como siempre las hacemos en el chat que tienen a su derecha, en el chat de mismo YouTube, pueden dejarlas libremente, pero por favor preséntense de dónde son, de dónde vienen y su pregunta. La pregunta la pueden hacer en español o en inglés, pero efectivamente después durante la discusión que voy a realizar con la profesora al final, esta será en español, yo hablaré en español y tendremos una traducción de parte de Natalia, nuestra traductora y es estudiante de nosotros, que nos ha acompañado en todas las charlas internacionales, así que sin problema pueden dejarla en español porque yo tengo que leerla en español para que quede traducida para la profesora. Además, comentarles que les dejé un link en el chat de YouTube en la cual ustedes pueden acceder a la charla en idioma original, tanto en español como en inglés, sin traducción, por si les es más fácil y cómodo verlo. Así que tenemos ahí doble transmisión gracias a las oportunidades que nos da esta plataforma. Bien, hoy tenemos una presentación espectacular. Tenemos desde Australia a la doctora Ebonie Río. La doctora Ebonie tiene una maestría en kinesiología y completó su doctorado investigando sobre el dolor en tendones, el tema que nos hablará hoy día. Y además investigó cómo el sistema nervioso central y el control motor pueden cambiar en personas con tendinopatía. Ebonie es investigadora postdoctoral en la Universidad de La Trobe. Su carrera clínica ha incluido la Australian Institute of Sport, Australian Ballet Company, Australian Ballet School, Melbourne Heart Football Club, Alpinton Sport and Medicine Center, en los Juegos Olímpicos de Invierno de Vancouver 2010 y los Juegos Olímpicos de la Juventud de Singapur de 2010 y Juegos Paralímpicos de Londres 2012. Es tanto una profesional clínica como investigadora en el Centro de Investigación de Medicina del Ejercicio y el Deporte de la Universidad de La Trobe en Melbourne, Australia. Quiero dejar con usted y presentarla ya a nuestra invitada, la doctora Ebonie. ¿Cómo estás? Ebonie, te veo muy bien acá. No sé si tú me escuchas bien.
Yes, I can. Thank you so much for your kind invitation and that lovely welcome. Wonderful.
No, gracias a ti, Ebonie, por estar hoy día con nosotros. Gracias por acompañarnos. Como comentaba, nos están mirando de todas partes de Chile, distintas ciudades. Tú sabes que Chile, estamos hablando hace un poco rato atrás, que Chile era uno de los países favoritos de tu hijo, parece. Aclárame eso. Y tenemos largo continente en el cual nos ven de todos lados y también de otros países. Mira, de Argentina nos están mirando también, te mandan saludos.
Oh, wow. Oh, fantastic. I'm so excited. So thank you, Gustavo and Mauricio, for the invitation. And Natalia, thank you in advance for your amazing translation so that everybody can learn from this.
Sí, muchas gracias también a Natalia por estar aquí con nosotros hoy día y permitir llegar a más gente hoy. Así que un gusto para nosotros, Ebonie, tenerte acá. Antes de comenzar, y a todos nuestros invitados siempre le hacemos la misma pregunta: ¿cómo has estado tú y tu familia y todo en la universidad con respecto a la pandemia por allá en Australia?
Thank you for asking. It's very different in different parts of Australia. We are all well, but Melbourne, Victoria, where I live, is still in lockdown. So the university is closed and we are completely online, but it means that there's no research able to be conducted at the moment. So it's very difficult, and I'm doing homeschooling with a 5-year-old and a 7-year-old who I mentioned may make a visit, but we'll hopefully not.
Bueno, no te preocupes si aparecen tu hijo, al contrario, va a ser muy grato verlos también. Estamos todos súper acostumbrados ya a esto y algo que nos ha mantenido muy unidos entonces como humanidad, para vivir algo muy similar todo. Así que, bueno, Ebonie, no te quito más tiempo. Está tu presentación lista y preparada, la gente te escucha muy bien, hay más de 65 personas conectadas y todos te escuchamos súper bien. Al final de tu presentación yo voy a volver con las preguntas que tienen todos en el chat, así que éxito y muchas gracias por estar acá hoy día, Ebonie.
Fantastic. Well, thank you again for having me. I'm so honoured and thrilled to be here. Thank you for joining me wherever you are. And I would like to acknowledge that I know a lot of people and a lot of countries are doing it very tough. So I'm thinking of you, and thank you so much for choosing to take some time to think about tendons. So I'm very excited to share this presentation with you today. It's a new presentation that I've developed just for you. I have made it very clinical. I would like you to understand how to diagnose tendinopathy. I'd like to take you through some very practical tips. If you're very interested in the physiology or the pathology of the condition, you can certainly ask me more questions about that at the end, but I've purposefully chosen to keep this quite clinically based. Okay. Oops. So just before we start talking about tendinopathy, I'd like to share with you our modern understanding of pain. So we know that pain is produced by the brain 100% of the time. And that's true of a paper cut, it's true of low back pain, and it's true of tendinopathy. Your brain will weigh up the available credible evidence. So some of this credible evidence comes from your body. It comes from activation of your nociceptors. So in the case of tendinopathy, if we think of our Achilles tendon, it's some sort of mechanical stimulus, possibly chemical as well. But when we do a movement, we provoke those nociceptors. They send information up to the spinal cord, which then gets relayed to our brain. And our brain decides whether or not it needs to protect that body part. So it weighs up the available evidence to make a decision around whether or not you need protecting. And if you need protecting, pain is an excellent way of changing your behavior. If you have pain, you're less likely to load. So it actually has lots of different ways of getting you to change your behavior. So we don't have pain in our body. It's always produced by the brain, which means we have the ability to modulate this input and modulate the experience. I'd like to explain why that's important in tendinopathy. And to start with, I want to pose the question, does the biology or does the body contribution matter? If pain is produced by the brain, could we make an argument that it doesn't matter what body part we're talking about, or it doesn't matter about differential diagnosis? So that's what I'd like to challenge you to think about now. The very best place to start, I think, in tendinopathy is to think like a tendon. So I would like you all to think like a tendon now for the next hour and a half or the rest of your life. It's up to you. And if you're a tendon, there are 4 loads that you can experience. The first load is tensile load. And tensile load is when you ask your tendon to store and release energy like a spring. For it to be high tendon load or high tensile load, it must be fast. That's what's high load for a tendon. So to give you an example, this would be running for our Achilles tendon. The tensile load is different for different activities. So for example, the patellar tendon, high tensile load, or when we ask our patellar tendon to act like a spring, is a big volleyball jump where we might be approaching the net and going from horizontal to vertical. So it's that change of direction, and it's very fast. It might also be in a tennis athlete who is changing direction very quickly at the net by lunging forward on one leg. So that's why we can see tendinopathy in our tennis athletes, but we can also see patellar tendinopathy in our basketball athletes who do much more change of direction than they do jumping. So even though it's called jumper's knee, we do see it not just in volleyball, who jump a lot, we also see it in tennis and basketball sports. But you might be surprised to know that running is not high patellar tendon load. When you run in a straight line, you don't store and release energy through your patellar tendon. It would take too long for you to actually use your patellar tendon spring. It would not be efficient. So running is not high patellar tendon load, which automatically can help you with your differential diagnosis. Because if someone comes into your clinic and they have anterior knee pain and they're a runner, you can start to think of differential conditions such as patellofemoral pain, because it actually won't be patellar tendinopathy. So our first load to think of is our tensile load. That's when we're asking our tendon to act like a spring. It's what they're designed to do. Our second load is compression, or a compressive load. And this is when our tendon is squashed against a bone. It's using the bone as a lever to increase the efficiency. So a good example is our Achilles tendon that comes down and inserts onto our calcaneus, and it's compressed as we go into dorsiflexion. And this is why people with insertional Achilles tendinopathy are provoked when we give them stretching exercises. That's why we never give stretching. It's why they're provoked if they're given the eccentric program off a step. It's because of the compression of the tendon against the bone in that dorsiflex position. But that can also help you, because what you can do is give advice around a higher shoe so that you're actually taking them out of compression when they're walking around. So if you understand these loads, we can not only appreciate how they got into trouble, what provokes them, but we can start to recognize which loads we can remove as part of their rehabilitation. Now, our third load is the most provocative for tendons, but it's also what they're designed to do, and it's also what our rehabilitation will need to progress them back to. It's called a combination load, and this is where you're combining a fast spring load into a compressed position. So a good example, if you can see in the picture, is changing direction for the Achilles. And interestingly, this can help us explain why Achilles tendinopathy can be seen throughout the lifespan. Because when we're young and athletic, we might have a sore Achilles doing, our track athletes or our field-based athletes. But also, we need to use our Achilles tendon as a spring throughout the lifespan. If we change direction, we'll store a little bit of energy in our Achilles tendon. If we step downstairs or step off a curb, we're actually still using our Achilles tendon like a spring, and often in that compressed position. So that's why even quite sedentary people can succumb to Achilles tendinopathy. Unlike our patella tendon, the patella tendon is exclusively used by pretty much our young, very athletic men. So the people that are capable of doing many jumps, but also our best jumpers, are almost the only people that get patella tendinopathy. So you wouldn't see patella tendinopathy in an older sedentary man or woman, or someone who does swimming or cycling or some sort of activity that is not using their patella tendon like a spring. So understanding these loads is actually vital in your differential diagnosis, but it's also going to help us in rehabilitation that I'll talk about later. So we've had our tensile load, our spring load. We've had our compressive load where it's squashed against the bone. We've had our combination load, which is the spring load with compression. So it's combining the first two. And our fourth load is a load of not high spring, but lots of movement. So we call this shear or friction load. And that's where the outside layer of the tendon, so the peritendon sleeve, slides and glides over the tendon repeatedly, but not in an activity where you're asking your tendon to act like a spring. And a good example is cycling for the Achilles. So if I'm cycling, I might go through lots of repeated plantar flexion and dorsiflexion, but I'm not using my Achilles tendon like a spring. So the load during cycling on the Achilles is shear and friction. It irritates the peritendon structures on the outside. And it is therefore a differential diagnosis because we're going to manage that condition differently. Now, I'd be very happy to answer any questions you might have around loads because it's just such an important concept to understand in tendons. So now that we understand load, we're going to now diagnose tendinopathy. And I have two key questions. They're not the only questions, but they're good questions to start with. My first question is, where is the pain? And this is pain during a load activity, not pain with palpation. The reason for this is that palpation is very sensitive. Lots of things can be tender, but it's not specific. It won't actually give you differentials between different conditions. For example, the patella tendon is one of the most sensitive structures in knee osteoarthritis. So if you're poking a patella tendon, you actually can't differentiate between patella tendinopathy and osteoarthritis. I think that's a very important thing to remember, that other things in the area can be sensitive. So it doesn't actually help you rule the condition in or rule other conditions out. So we're asking people where their pain is with load activities. And critically, we're asking them about the specific activities that give them pain. So our questions are, where is the pain and what aggravates the pain? They're my first two really important questions, because tendinopathy has some quite unique features. Our pain remains very localized with tendinopathy, and it's aggravated by these high tendon loads, these spring type loads, particularly with compression. So I'd like to explain that using the Achilles as an example so that you can hopefully understand what I mean. So if we're doing a clinical assessment of our Achilles region, we need to remember that we can have our insertional presentation where people will point with one finger, and we can have our mid-portion presentation where people tend to pinch in the Achilles region. They tend to use a pincer grip to show us that mid-portion presentation. So they're our most common Achilles tendon presentations. Because I told you that high tendon load is when we do something fast, tendinopathy is a condition where rate-dependent loading is really important. If fast activities are provocative, the converse is that static or slow activities are less provocative. This is a very, very important concept. I'm going to show you how to use that information in differential diagnosis. So this is exactly what I would do with my patient. I would ask them to start with double leg calf raises, and I'm going to ask them two questions the entire assessment. How much is your pain? 0 to 10. And where is your pain? It's very important I ask where. So I'm going to start with low load because this is slow and it's double leg. So I'm going up and down on 2 legs, and I'm asking them, how much is your pain and where is your pain? I'm then going to progress them by doing single leg calf raises. It's still a slow activity, but it's now all body weight on 1 leg. I'm going to ask them, how much is your pain, 0 to 10, and where is your pain? I'm then going to progress to double leg continuous jumps. Do you see how I've increased the rate of loading? I'm asking the Achilles tendon now to act like a spring, but it's on 2 legs. I'm going to ask, how much is your pain, 0 to 10, and where is your pain? I would then progress them to single leg hops, where I'm asking their Achilles tendon to act like a spring. I'm going to ask them, how much is their pain, 0 to 10, and where is their pain? I could then progress them to big hops and ask them to really do an explosive activity for me. I'm going to ask them, how much is their pain and where is their pain? And I hope you can see that I'm being repetitive on purpose. This assessment allows me to diagnose tendinopathy, and I'm going to show you how. When I start with my double leg calf raises, these are often not provocative for Achilles tendons, so they might say 0. When I do a single leg calf raise, they might say 1, but it's very localized, either mid portion or insertion. They don't move or spread. It's very localized. When I ask them to jump and I'm starting to put some spring load on the Achilles, this will start to provoke them because it's the speed, it's the spring. So they might say, oh yes, that's a 4, but again, it's very localized in their description. When I ask them to do my single leg hops, I get an increase in pain. Oh yes, that's a 6. So I've seen an increase in pain with an increase in tendon load, but it's remained very localized. That might seem very simple, and it is, but I'm going to show you how you would differentiate the peritendon, so the outside structure of the tendon. So the first thing is you will get fantastic information in your subjective history. your patient will say, oh yes, I did a lot of cycling. And you'll think, oh, that's not a spring load. I remember from Ebonie's lecture, that's a shear and friction load. So you'll start to think this could be a peritendon issue. Then when you do the shear and friction activities, this is provocative. So they might say, oh yes, that's a 2 out of 10 for double leg calf raises. And my other question, where is the pain? They'll show you the entire tendon. They'll be quite diffuse in their description, usually. With the single leg activity, they'll still say a 2, they'll still say a 2 out of 10. So what you do not see is a dose-dependent increase in pain as I've put more load on the tendon. They'll also be quite vague in their description of pain. It won't be so specific. And when we go to our jumps and our hops, where we're not going through the range of motion, these are often pain-free. So it's so important to go through this progressive load assessment so that you can gather that information. My other tip is to use a stethoscope. If you have a stethoscope at your clinic, you can ask your patient to lie prone on the physiotherapy plinth, and you can place the stethoscope over the Achilles tendon and you can hear the crepitus. And that's a very valuable assessment tool. I'd like to give you one other little tip, if I may. The people that are runners can still get a peritendon issue. And this is where understanding pain behaviour is very important. If you have someone with tendinopathy, their pain warms up as they get going. So they'll often say to you that it's very sore and stiff at the start, but then they feel better, only to be worse the next day. However, someone with a peritendon issue can get worse the longer they go. And the reason for this is if their calf is not very strong, the longer they run and they fatigue, they can just start going through a bigger range of motion. So tendon pain behaviour is very important. We know about the warm-up phenomenon, so it's really important to really ask your patients the question, does your pain warm up or does it get worse the longer that you go? Because that will be really useful information. I hope everybody can see why it's so important to do this progressive load test. If I just squeeze a tendon, I can't differentiate between Achilles tendinopathy or the peritendon or a sural nerve irritation, because all of those things will hurt to squeeze, but I'm going to manage them very differently. What about if I just went straight to a hop? That's likely to be provocative for a lot of conditions in that posterior ankle region, whereas it's the tendon that has the specific features around rate of loading. So I hope you're inspired to do this in your clinical practice, but I'd also like you to remember this the next time you're reading tendon research, because often people that are included in tendon research have pain with palpation or pain with a hop test. So I would consider that we have a lot of variety of conditions currently included in our tendon research, and that makes it very difficult to translate our findings. I also wanted to give you, and I'm very happy if you would like a copy of these slides, it's no problem. I wanted to give you some clinical things to remember, some clinical tips to differentiate between these different conditions, because the Achilles can be quite complex, actually. If we start on our left and we're looking at our mid-portion Achilles tendinopathy, I put the little pink markers on there to show you the region. And the differentials for the mid-portion would be our peritendon. And the way you would differentiate that would be remembering your loads. The person with mid-portion tendinopathy is going to be the person that uses their tendon like a spring, their pain warms up. The person with a peritendon issue is going to be someone that might be a cyclist or a swimmer. They do a lot of repetitive activity, but it's not a lot of tensile load. It's not a lot of spring load. And you can also use your stethoscope to help you. If we consider our middle column, and we're thinking of our insertional Achilles, they point down on the calcaneus, usually a little bit laterally. And there's probably two key conditions to differentiate for the insertionals. And the first one is our superficial bursa. Now, the superficial bursa sits actually between the skin and the tendon. So it's not the retrocalcaneal bursa, it's a bursa that's not part of the muscle tendon junction. And people that have irritated their superficial bursa have irritated it with some sort of footwear. So their shoe is either rubbing or compressing on the back of the superficial bursa. So the best tip that I can give you is people with insertional Achilles tendinopathy will prefer being in shoes because they will not like being in dorsiflexion. They will like the removal of the compression. But people with an irritated superficial bursa will say to you, I hate being in shoes. I can't wait to take my shoes off at the end of the night. And you'll think, oh, that's superficial bursa. You'll remember it now. And that's important because our strategies for managing those are quite different. And I'm very happy to talk through those conditions at the end. The other one I'd like you to be aware of is posterior ankle impingement. So just making sure the back of their ankle joint is not giving them any problems. And a little tip for differentiating those is that someone with insertional Achilles tendinopathy won't have pain at the top of the calf raise because they're completely out of compression, but someone with posterior impingement will. And our last one over on the right is our plantaris. I just need to move my face out of the way of the screen. The people that have a plantaris irritation often point quite medially on the Achilles tendon and they're quite high. So rather than pinch the way the people with mid-portion Achilles tendinopathy do, they tend to run their finger along the medial border. Now, because the plantaris tendon is stiffer than the Achilles, people that have a plantaris irritation are also bothered in dorsiflexion because in dorsiflexion, that plantaris actually pushes or rubs on the Achilles tendon. So people with plantaris tendinopathy will point around this middle region, but they'll prefer to be in shoes. They'll hate that compression. They'll hate the eccentrics off a step. So it can start to be a bit of an indication that they're a bit different. Okay, I know that's a lot of information, but I'm hoping you're getting some clinical tips. Now, I told you that pain is produced by the brain 100% of the time, but now I'd like to consider what we know about nociception in tendinopathy. And I can answer that very quickly. We know very little. Actually, we know much more about what doesn't drive nociception. So there have been theories over the years, and most of these have been disproven, but I want to show you how this still helps us with our patients. We can still use this information. And what I'd like to start with is a fantastic systematic review by Nickel in 2017. And this looked at the way terms and terminology impacted people's expected treatment. And I've pulled out one example for you, but it's a wonderful paper. I would encourage you to read it. To give you an example, if an injury was called a broken bone, then 56% of people thought they needed a plaster cast. But if this same injury was reported as a crack in the bone, only 13% of people thought they needed a cast for the same injury. So can you see how every time you're talking to your patients are updating their understanding of their condition, but also what they think they need to do in terms of management. So I'd like to show you the implications for tendons with just 2 examples. And the first one is the use of the term tear. We need to be very careful with the term tear. I'm not talking about complete rupture. I'm talking about the diagnosis of a partial tear. If you consider something like patellar tendinopathy, it has what we call an insidious onset. It's a load-related condition. It's not an acute incident. We know that tendinopathy is unrelated to sonographic findings. So it's unrelated to ultrasound. If you have changes on imaging, it is a risk factor for pain, but there is a disconnect between pain and imaging findings. We know that people's imaging findings don't improve even when they are pain-free. We have a very low accuracy with diagnosing tears on imaging when people then go for surgery. But if you say to any of your friends or family, what would you do for a torn tendon? No one will answer exercise. Everyone will think that they need to rest or perhaps have surgery or use some sort of injection therapy to heal the tear. So if we're not very good at diagnosing tears on imaging, we need to be very careful using that word, because people will not want to load their tendon. They'll be very fearful. Now, this is my second example. No one is allowed to use the term tendinitis. The reason for this is that the clinical implications of using such a term are very dangerous. If you say to any of your friends or family, what would you do for tendinitis? Everyone will think of very passive therapies to reduce the inflammation. They'll think of rest and ice and anti-inflammatory medication. And we know that those are not effective in tendinopathy. There are cytokines in tendinopathy, but not in the same way as an acute inflammatory response, like if you strain a muscle, where you get bleeding and inflammation and proliferation and a scar. It's a very different process. So it's so important that we use the term tendinopathy so that our patients are informed about the correct understanding of the condition, but also to help with our adherence. If our patients are saying, I have Achilles tendinitis, and we don't correct them and educate them, then you could write an excellent exercise program, but it might not be well adhered to. Okay, so I posed a little while ago, does the bio matter? Does the biology matter? And it absolutely does. So even though the brain is experiencing pain from the Achilles region, it's important as to whether or not it's tendinopathy or the peritendon, because it completely changes our management. It completely changes the loads that we'll remove. It completely changes our start point. To give you the example, if it's the peritendon, I would absolutely not start this person with calf raises, because it's a movement load and it will continue to provoke them. But if I have someone with Achilles tendinopathy, I will definitely give them calf raises. So it's so important for our education and our start point. Okay. The other thing that I'd like to show you, this is one of my patients, and I'd like to pose the question to you that even if we knew the nociceptive driver in this person, would it change my management? And I would contend that it doesn't. Pain serves to protect. It's actually helping this patient by stopping him from overloading. Until we actually address his function, we won't do anything about his pain. So we treat humans, not tendons, and we treat humans, we treat their pain and their function via education and exercise. So again, I'd be happy to share these slides with you if you would like them, but I wanted to provide some top tips. In our subjective assessment, we need to understand what loads provoke their pain. And is that high load, is that a spring load for that tendon? You could ask in the Achilles region, are you better or worse in shoes? Because for an insertional Achilles tendon, they will love being in shoes with a heel because it reduces that compressive load. But for a superficial bursa, they won't like shoes at all. So it can really help you with directing your management. I always ask if people have pain with low tendon load. If I have someone with anterior knee pain and I'm not sure if it's patellar tendinopathy or patellofemoral joint pain, I'll ask them about cycling because it won't bother a patellar tendon, but it might bother your patellofemoral pain. So it can give you some useful information. I always ask, where is their pain and does it move or spread around, because tendinopathy remains so localized. And I also like asking the runners whether or not it warms up or gets worse the longer they run, remembering that a hallmark feature of tendinopathy is the warm-up phenomenon. When you move to your objective assessment, we're really looking to establish that our pain remains localized during our progressive load tests. If you just use something like palpation or a hop, please remember that that will provoke many conditions. It actually won't differentiate for you. We do know from research that we have difference in hop strategies. So if we have a patient with patellofemoral pain, sorry, Natalia, if we have a patient with anterior knee pain, if this patient does a lot of valgus with their knee and gets into a lot of knee bend, they flex their knee a lot, that is a strategy that is associated with patellofemoral pain, not patellar tendinopathy. So even watching how someone hops is very helpful. People with patellar tendinopathy hop with a very stiff knee. They won't want to use their patellar tendon like a spring. And also they don't have the same deficits in their hip. We don't see that valgus. So that is a fantastic piece of useful information for you, just watching someone hop. I said before that I don't poke around to see what's sore, but I do absolutely use my clinical skills. For example, for anterior knee pain, the patellar tendon is extra articular. It's outside of the joint. So if someone has a knee joint effusion, I'm not thinking that they have patellar tendinopathy. They have some sort of intra-articular condition, which could be patellofemoral, it could be related to trauma, but it's not their tendon. And I'm so interested in what people tell me or what I see when I'm doing my objective assessment. So if tendinopathy is associated with rate of loading and it's our very fast activities, people with tendinopathy can complete our static and our slow loads without problems. So if someone has increasing pain during a static or a slow load contraction, I'm highly suspicious that it's something else. To give you an example, people with patellofemoral joint pain hate the heavy leg extension machine, but people with patellar tendinopathy love it. Okay, so what next? We have listened to our patient and we've assessed them. We have established their goals and the outcome measures that we will use. But now what I'd like to do is, just before we get to the point of prescribing an exercise program, I just want to add a little bit of complexity. I just want you to understand one more thing, if you can, for me. And this is our consequences or manifestations of tendon pain. So this is the brain and the motor cortex and our spinal cord. It's very important. So as part of my PhD, I was very interested in how our brain or our motor cortex actually drives our movement or drives our muscle. So the analogy I'm going to use with you today is the brake and the accelerator of a car. So when we do a movement, it is a balance between our excitability and our inhibition, or our accelerator and our brake. And everything we do balances those things required for the task. We can use a piece of equipment called transcranial magnetic stimulation. It's a magnet that goes over your motor cortex. And what we do is we provide a stimulus. This travels down your spinal cord, and we record this as a twitch in the muscle. So in the case of patellar tendinopathy or knee pain, I was interested in our rectus femoris muscle, our quadriceps muscle. And what we found is that people with patellar tendinopathy had very different control of their brake and their accelerator to our people with no pain, but also had different control to people with patellofemoral joint pain, which I was very interested in. So if you have patellar tendinopathy, it's like you have one foot on the accelerator and one foot on the brake. You actually have an increase in that excitability, but you also have an increase in your inhibition. It's like they have one foot on the accelerator and one foot on the brake. And I'm not sure if people are very good drivers, but in Melbourne, learner drivers are not very good. So that's the analogy that I often use when I'm teaching my students. So the physiotherapist in me was very interested in the graph on the right. And the graph on the right shows the change in their profile where they had no ability to modulate their excitability. And I thought, I wonder whether or not we address that very well with our rehabilitation. So then I was very interested in the relationship between pain, motor drive, and strength, capacity, and function, because tendinopathy is complex. It's actually all of these things. People present with pain, but they present with these deficits that we can measure, so strength and function. But now we also have the brain and the spinal cord to think of. We know that load and exercise is our best intervention for addressing pain and capacity. But I was interested in hitting the bullseye. What intervention could we use that would be capable of addressing all three of these complex contributions? And to understand that, I was looking in the neuroscience literature, and the neuroscience literature is a lot of fun. So I would encourage you to look. And I'd like to explain this graph to you. If you look at a skill, which is called a visuomotor skill. So that's where you're watching someone do a movement and you're copying that movement. So this is the motor part in real time. And you're copying it for the speed, you're copying it for the range of motion, and you're also copying it for the time under tension. Everything about that activity and how you're doing it, you're mimicking in real time. It takes a lot of brain power, actually. The next condition is if I get you to do just self-paced strength. So if I get you to do an activity where you go to the gym and you put the weights on and you start doing the exercise, and you're listening to music and you're thinking about dinner or hoping we can go on a holiday soon, you will get stronger over time going to the gym because you'll get changes at a muscle level and you'll get some physiological changes, but you actually don't change your motor drive. You don't change your brake and your accelerator. If we get you to combine your strength activity with some sort of external stimulus. So if we use a metronome, what we actually do is we actually make your brain work very hard. We change your brake and your accelerator because your brain needs to work out how to get that movement done in that constrained amount of time. So rather than me just moving my leg through the leg extension, my brain has to think, okay, I've got 3 seconds to do a concentric and 4 seconds to do an eccentric, I have to really plan that activity. I have to be very focused. So something like a metronome, this external pacing, is one method of incorporating load, which is important, but also addressing our brake and our accelerator. And this was a nice reminder for me that repetitive, unskilled movements do not result in changes to the motor cortex. And people with tendinopathy have changes to their motor cortex. So we need to consider how we can alter their motor cortex. So I'd like to summarize that for you in terms of what different interventions may address. So people will often ask me about injection therapies. And this is what I would say to a passive intervention that's used on its own. Your passive intervention, if I do, so this is one of my patients on the top right corner, if I give him an injection into his patellar tendon, I've not addressed his strength. I've not done anything about his motor drive. So I should not be surprised that this is ineffective. He will continue to experience pain and reduced performance and frustration and an ongoing focus on the pathology because I've not done anything about his pain and function and his motor drive. What about if I prescribe some sort of load activity? And we might all do it very differently. And that's okay. I don't think there's one way to rehabilitate tendinopathy. I think it's highly individual. If we give a strength-based activity, but we give a self-paced activity, which is what we currently prescribe, then I'm not saying that this is wrong. I'm saying that this is potentially our current clinical challenge where tendinopathy is difficult to treat. You can often see it on the other side, or it often comes back. If we go to another extreme and not worry about the strength and just worry about how we change the brain, then I would contend that we don't have sufficient body capacity to perform our task. If someone can only do 4 calf raises and they want to run a marathon, it's not all about the brain. We need to make sure we've rehabilitated their body. So we would propose, and we wrote this in a paper, that our rehabilitation needs to incorporate strength and progressive load, but using some of these newer concepts like the external pacing so that we can optimize all levels, the brain, the spinal cord, but also do really good rehabilitation for the body. So externally paced load using a metronome is one method of turning our terrible learner drivers into our Ferraris or whatever car that is. Okay, so let's put all of that together. We need to consider what loads we can start with because we need to remove our provocative loads, but we can't do complete rest. And I'm going to show you why. So Jill Cook taught me this many years ago, and I love it. I find it very effective. If this is the capacity of your tendon or bone or muscle, it only ever just exceeds the load that we put on it. So capacity and load are very closely related. If your patient with Achilles tendinopathy did a very long run and got sore, they overloaded, they might have been told to rest. So they drop their load for 2 weeks. What happens to their capacity? It reduces. Then they go back to running and they think, but I haven't overloaded. I used to run 5 kilometers 2 weeks ago. They don't think they've overloaded, but it's overload for their new capacity. It's a relative overload. But because they have pain, they think, oh, maybe I didn't rest long enough. And they drop their load again and their capacity goes down. And this is true of all our invasive therapies. Every time we require downtime after doing it, we're actually reducing people's capacity. So we need to remove provocative loads, but not all loads. So I wanted to give you some tips about how to remove some of the provocative loads. If you consider compression, then we would need to remove stretching. Stretching is compressing the tendon against the bone. Eccentrics over a step compresses our insertional Achilles. It compresses our tibialis posterior, so we need to remove it for those conditions. But this is why adding a shoe with a higher heel can be helpful for both of those conditions. We need to modify exercises. So if we think of something like our hamstring tendinopathy, we would remove the deadlift that you can see on screen because they're going into a very compressed position. But I wouldn't take them out of the gym. I would modify by getting them to do a prone hamstring curl. So they're in hip neutral, they're doing a slow exercise for the hamstring, which is fantastic for their hamstring, but there's no compression. So this is why understanding load and why I spent time at the start is very important. We need to manage or remove our speed when we consider our tensile load. So the converse of that is that anything static or slow is a very safe start point for a tendon. If we have a peritendon issue, we need to treat that peritendon issue first, and I'm happy to take any questions about that. But they actually do very poorly with isometrics and isotonics. They're very provoked with load in the early stages. Okay. So the question that I often get is which exercise? Oh, should we be doing isometrics or heavy slow resistance or eccentrics? I hope you can see that it would never be one of these. To truly rehabilitate people back to sport or movement, we need all of those different components. I'd also like you to make sure that you don't discard research from the past that informs our clinical practice. What I mean by that is the heavy slow resistance protocol and heavy load is fantastic, but I don't use the heavy slow resistance protocol from the paper because it's double leg. And we know that people with tendinopathy have unilateral strength deficits on their symptomatic side. So if we provide a double leg exercise, we never address those asymmetries. So it's important that you don't just use recipes that you find from research, that you adapt it to the person in front of you. So I do heavy slow resistance, but I do it single leg. I use a lot of cross education. That is the concept of strength training one side, and you actually get some transfer of strength onto the other side. And the last thing that I'll say on that is we really need to consider the role and function of tendon. You could never give just an isometric program and someone would be better. You could never give just isotonic or heavy slow resistance because you haven't retrained their spring. But you couldn't just do a plyometric program either if you haven't given them the basis and the strength work. I think we have a visitor. You okay, mate? No? Okay. Cooper says hi, he's 7. So I wanted to summarise for you in this slide something that Jill Cook and Craig Purdom have been doing. Jill Cook and Craig Purdom have been doing for a number of years. So complete credit to them for really shaping how I manage tendinopathy and just how progressed it is. If you are going to use isometrics, it would be early, it would be a way in, it can reduce pain and reduce inhibition. Remembering if you have someone with, hang on one second, sorry everybody. Sorry everyone. So remembering if you have someone whose pain is worse with isometrics, really consider that differential diagnosis. When we're considering our strength work, this is a critical phase. This is the foundation for preparing so that you have a nice strong muscle to then do your spring-like activity. When stage 3 and 4 are highly individualized, it's based on what that person needs to be able to do. So my rehabilitation for an elite Olympic athlete is very different for a lady that would like to walk around the block with her grandchildren. So this is why you'll never be able to take a recipe from the research and apply it, because everybody has a different start point and a different set of goals. And again, I'm happy to give you any clinical tips that you might like in the question time. So I would really encourage everyone to be evidence-based. We should all be using the evidence to inform our practice, but not recipe-driven. So being evidence-based doesn't mean that you have to do that particular protocol. When we do research, we ask very specific questions. We compare this type of contraction with this type of contraction in this environment for a very short period of time to ask a question. But you would never consider that that's complete rehabilitation. So my top tendon pain tips: what to listen to, understand your tendon load, know what is fast spring load for each tendon, know your tendon pain behavior, that they have a warm up, they're worse the next day. Teach your patients to listen 24 hours after the load. You should start with your non-provocative loads, but you can't stop there. You can't ever stop with just an isometric or an isotonic. You need to understand function. You need to hopefully be excited by the brain and understand that this is why there's no magic tricks for tendons. It's all about slow progressive load. So I'd really very much again like to thank you for the invitation. I'd especially like to thank Natalia. Australians talk very quickly, and I hope that was okay. I kept trying to slow down. I'd be so thrilled to take questions, and thank you so much for joining me.
Muchas gracias. Muchas gracias, Ebonie. No sé si me escuchas. Estoy ahí volviendo pantalla.
Yes, I
Perfecto.
can.
Perfecto. Muchas gracias por tu presentación. Tienes saludos de todos lados, como te decía, mucha gente mirándonos de distintas partes de Chile, también de Argentina, de Ecuador, de distintos lados. Y hay bastantes preguntas, así que te voy a ir comentando una por una y dando una conversación acerca de los contenidos que estuvimos revisando. Excelente presentación. Mira, Tomás, un colega chileno, nos dice: ¿qué sugieres para el manejo del dolor y la carga en personas jóvenes, menores de 18 años, que cursan con tendinopatía rotuliana asociada al crecimiento y la sobrecarga asociada a este mismo fenómeno? Saludos, te mandas desde Viña del Mar, una ciudad hermosa de acá de Chile.
Thank you for your question. Managing patellar tendinopathy in those young, very talented men is very challenging because they don't want to load modify. They don't want to reduce their load. And remember, we talked about load and capacity. This is true even in our growth conditions, even in our Osgood-Slatter conditions and our severs, that they still have relative overload for their current capacity. So where possible, we try and modify their load, and that is not easy to do. We are also much more likely to use strength training now than we ever were. We used to be very nervous about our athletes, our young athletes, doing weights, but I'm very comfortable giving strength-based exercises for our young athletes because you consider the very high ground reaction forces that they need to absorb. When we're asking them to do something like calf raises, it's well below that. So if I have an athlete with patellar tendinopathy or Osgood-Slatter condition, my first thing is to try and reduce the number of sessions per week to give them time between those high tendon loads. So reduce frequency first if you can. I try and reduce the load on the anterior knee by improving the whole kinetic chain. To give you an example, when you land from a jump, the calf absorbs 60% of the landing energy. So if I can improve that athlete's calf substantially, I can reduce the load that is transmitted to the knee. So while I would try and do some quadriceps exercise, doing a seated calf raise for your soleus and doing a standing calf raise for your calf is also going to be something that's very effective. So don't be afraid to prescribe exercise, but also look at the frequency of their load and try to negotiate sessions. But it's a very challenging one. I wish you luck.
Y con respecto a eso mismo, Ebonie, ¿qué sugerencias tú das acerca de ciertas banderas rojas o atención, ¿no es cierto?, que tengamos que tener frente a las diferentes cargas y cómo se están, cómo decirlo, se están incorporando, digamos, en esta tendinopatía? ¿Cuáles son para ti los aspectos más importantes a considerar a la hora de poner alerta, ¿no es cierto?, y cambiar quizá el rumbo de tu intervención?
Very good question. I think I've understood it. Please correct me if I have not. We teach our athletes, we teach our patients to listen to their tendon 24 hours after the load that you have put on the tendon, which is why it's very important to be very considered and very progressive. Because if we pay attention to our tendon during an activity, our tendon can be very confusing. It can be very sore at the start and people might actually underload, or it can warm up and people can do far more than what they should. So we don't get people to modify what they're doing based on how they feel at the time. They do a very defined load, and we listen to the tendon the next day, which is why it's important to change one thing at a time, because then if they flare a little bit and we'll know exactly what the activity was that we added. If we add 2 or 3 different exercises, we might flare them a lot and we also won't know what it is. The final important thing is to remember that people with tendinopathy are not provoked by our slow loads. So even if someone flares, they will feel better going to the gym the next day and doing their strength work. They shouldn't rest. They'll be better for doing their strength work. I hope that answered the question.
Sí, perfecto, perfecto. Muchas gracias. Bueno, eso fue una pregunta mía que aprovecho de entremezclar con la gente, con las preguntas de las personas. Tengo acá a mi lado las preguntas para que no creas que no te estoy poniendo atención, porque tengo distintas pantallas, monitores. Te pregunto, mira, te preguntan desde Ecuador, un país precioso. Si tienes la oportunidad de ir, te lo recomiendo. Ronnie Paredes nos pregunta, ¿cómo realizaría la intervención con un paciente con una tendinopatía crónica que no mejora a la carga progresiva y tiene dolor nociplástico? Te manda saludos desde ese hermoso país, Ecuador.
Hello. Thank you. That is an excellent question. Some people that I see that have chronic tendinopathy still have a very close relationship between their load and capacity, and we can work out what the deficits are that have not been addressed. And it might be something like the motor cortex. It might be that we add external paced load into their program. It might be that they've completed a very good strength training program, but no one retrained their spring. So the first thing we'll do is look at their program in a lot of detail. Did they do single leg or double leg exercises? Did they add additional load? You know, we're very, very picky with their program. The other part of that question is that sometimes we see people that have had a lot of interventions, and this is now much more complex. It is not a straightforward tendinopathy. If you have a lot of injection therapies, if you have a lot of shockwave, you can end up with a different condition. So then what we need to do is consider how that changes our management. And it might be that we can no longer just listen to pain the next day. To give you an example, we might come up with a pain score similar to the Silbernagel protocol, where we get people to listen during the activity. It might be that they actually never had tendinopathy as a condition, and it's been made complex because they've had a lot of injections into their tendon. So now their tendon is very provoked. So I think if we're talking about, remember that pain will always be there to protect, and really good education and exercise that promotes self-efficacy is really important. But that's only one component of the overall management.
Excelente, excelente. Mira, tenemos muchas más preguntas. La gente, estamos casi 70 personas conectadas actualmente. Eloísa nos pregunta, te manda saludos, dice, hola, ya mencionaba las diferencias en cuanto a carga sobre el tendón y paratendón en Aquiles. ¿Qué sucede con las cargas en la fascia plantar? ¿Cómo deberíamos progresar en la aplicación de las cargas para esta estructura?
That is another fantastic question. Thank you. So there is research in the plantar fascia by Michael Rathler's group that shows that you increase the windlass and you actually dorsiflex the big toe. That can be very provocative for people with plantar fascia pain. So that's why in the morning when they first wake up, they really hobble because they actually don't want to extend. They don't want to invoke that windlass mechanism. So that's why they can hobble. So in people, this is what I like to teach my students. If you find that protocol effective, fantastic. There's research for that. I'd like to give you an alternative, because some people find that so painful that they're not adherent. So I think as clinicians, it's important that we have tools, because not everything will work for everybody. So I'd like to give you an alternate. I'm not saying don't use that. We might use a step. And so this is my step and this is my foot. And rather than going up high and actually going into extension, what we'll do is we'll keep our big toe in neutral, and we might go slightly below the step and just up to plantar grade or slightly above. So I'm getting some fantastic work through my calf, through my Achilles, that's continuous through my plantar fascia. So it's actually a continuous structure, but we don't have a muscle attachment directly to load. So we need to load through the calf. And that is a way of loading through the plantar fascia that is much more tolerable. But what I will say is you need to be very aware of Baxter's nerve. So Baxter's nerve is your tibial nerve comes down and splits into the medial plantar nerve and the lateral plantar nerve. And it splits right where people get plantar fascia pain. So it's often missed as a diagnosis. And if you get someone off a step going into dorsiflexion, it will irritate Baxter's nerve. So that can help you with your differential. If you try this exercise and they're worse, you might need to do some work through the path of their nerves, some lovely flossing before you do some load. So this won't bother a plantar fascia, but it can absolutely bother someone with a neural presentation. So how people respond to your exercises can really help guide your clinical decision-making as well. That's a very good question.
Por supuesto, sí. Estaban también preguntando con respecto a esto otras personas y nos dice, por ejemplo, del trabajo de Radcliffe, sabemos que la tendinosis patelofemoral responde como un tendón con respecto a la carga, la fascia plantar, perdón, responde como un tendón respecto a la carga, pero tal vez no sea un programa para todos los pacientes por igual. O sea, deben haber efectivamente diferencias como tú las estás mencionando, ¿no?
I agree. I think that is an excellent point. The person in front of you might have diabetes. They might have lots of different conditions for you to consider as part of your management. I think it needs to be very individual. And that's why I was saying that I think options are very good for clinicians, because I think clinicians are very good at helping direct people. I think researchers are very bad at that. They want everybody to respond to the same thing. So we're very black and white. It helps everyone or it helps no one. And the answer is always somewhere in the middle. And that's what clinicians are very good at doing, is matching which patient will respond well to tape, which patient will respond to this exercise, but I might need to also add in this exercise, because mixed conditions are very common. You can have an plantar fasciitis as well as that neural irritation. You can have both. And clinically, you work that out, that you might need to manage that nerve first before you can load the plantar fascia. So I think it's an excellent point that we need to tailor and individualize.
Y con respecto también, bueno, ciertamente históricamente se ha discutido la relevancia de un tipo de ejercicio con respecto a otro desde un punto de vista del tipo de contracción, ¿no? Y hay una pregunta de Francisco, nos hace una pregunta: muchas gracias por tu presentación. Dice: ¿cuál es tu opinión con respecto al cuestionamiento actual que existe con respecto a la efectividad del ejercicio isométrico versus el excéntrico?
Thank you for your question. I think it's another very good question. I would like everybody to consider that it will never be one or the other. If you have a patient in front of you that has very poor capacity, they can do 4 calf raises and they would like to run a marathon. Neither of those exercise interventions will be effective for that patient. The isometrics might be a start point to reduce their pain, but they need to do strength work. Just getting them to drop off a step won't be effective. If I have someone with patellar tendinopathy and I only do quad-based exercise, again, I've not used the calf as a way of unloading. So the answer is it will never be one or the other. So this is where research really gets it wrong. Clinicians don't prescribe one exercise. Clinicians prescribe different types of exercises. So the thing that I would like you to remember when you're reading research, I'd like you to read the methods first. Don't worry about the abstract, read the methods. Find out who they included in the study. So if you look at the studies currently in the knee, and I'm not going to say patellar tendinopathy, I'm going to say the knee. If you look at the studies in the knee, they are often people who are sedentary. These studies that are predominantly women, whereas we know patellar tendinopathy is very uncommon in women. And they include people that don't get patellar tendinopathy. They include, in one of the studies, there was one jumper. So don't read the title that says this exercise type is or isn't effective in this condition. Go to the methods and see how they diagnose the condition and see if you think that's reflective of how you diagnose the condition. So I would look at some of those papers and I say, I agree with your findings. In a group of people with anterior knee pain that hurts to poke, you found that isometrics didn't help immediate pain. I actually agree with that. But I don't agree that they have patellar tendinopathy, because I'm not interested in pain with palpation. I'm interested in load-related pain in people that use their patellar tendon like a spring. So it very much comes down to the fact we don't agree worldwide how to diagnose the condition. That is a very big problem. That is a very big problem for me. It means we have a very heterogeneous group of people included in research, and poor clinicians are trying to translate research that is actually impossible to translate because it is so variable of who's included. So I think it's incredibly important to look at the research. This is how I define tendinopathy. I define tendinopathy as rate of loading. So the converse is a static or a slow exercise won't provoke those people. That's how we define it. If you define it as pain with palpation, I can't make the same claim. I wouldn't necessarily agree with the same findings. I think we need to work out how to use all the different exercise types as part of our management. It's never one or the other. I never just do isometrics, of course, but I don't stop at strength work either. You really need to do that spring. It's very difficult to research though, because that's so individualized. And in research, we like to compare two things to see which one is, you know, superior. But that's not what happens in practice, where your patient is coming to see you until they achieve their goal, not, you know, for a 4-week study period. So it's very different.
Sin lugar a dudas. Ebonie, te voy a pedir si nos puedes dejar de compartir la pantalla para que nos veamos mejor. Así la gente nos pueda ver mejor nuestras caras al discutir. Muchas gracias, Ebonie. Mira, hay otra pregunta también de Manuela, que tiene relación también con respecto a finalmente la forma de abordar la patología patelofemoral. ¿Qué experiencia tú has tenido, dado que existe muy poca investigación con respecto al tratamiento sobre la banda iliotibial? Es una pregunta que nos hace Manuela.
Thank you, Manuela. I don't, I'm not the expert in that condition. I do see a lot of people with anterior knee pain, and we use a lot of taping techniques to reduce people's pain to allow them to load. So I use, for example, a diamond tape around the patellofemoral joint that, you know, tries to sort of lift the patella a little bit. I will strengthen through the hip, and I'll strengthen through the calf, and I'll, you know, might use some orthotics if it's appropriate. I think the IT band being tight and the VMO being weak, that's been challenged a lot now. We now know that the whole quadricep is actually atrophied, and it's just that physiotherapists are very good at seeing the VMO. But if you look at the MRI, it's actually the entire quadricep. Also, the VMO is not selectively innervated. So if you have a weakness, it is the whole quad. So I don't do a lot. I don't do as much through the IT band as I did when I went through university. I've moved away from that. But I'm not saying that that wouldn't be something for your patient that might be useful to do.
Perfecto. Ebonie, mira, vamos a ir ya con las últimas preguntas para no quitarte más tiempo. Tú estás al otro día, estás en el futuro en comparación a nosotros. Allá en la mañana, acá estamos llegando a la noche. Y vamos a respetar tu actividad. Mira, hay una pregunta de Tamara muy buena. Dice, en base a lo comentado en cómo abordar el cambio de percepción a nivel del cerebro, ¿cómo administras el reposo para no generar esta baja de condición al reintegrarse en la actividad? Una muy buena pregunta con respecto al descanso, ¿no?
Great question. If I am very confident that I have someone with tendinopathy, I actually don't rest. I would automatically start them on isometric or isotonic. Either is a fantastic start point. The isometrics can be useful for the person that is very fearful, because it's a very safe way to start. But if you do start there, don't keep them on that exercise very long. Please move them on to isotonics. I would also give them exercises for their other leg and explain to them about cross education. So we're actually getting you stronger by training your other side. And I would give them their exercises for the remaining kinetic chain. So if I have someone with tendinopathy, I actually don't rest, because we have safe start loads. If I have someone with a peritendon condition, that's different. I actually do rest them. I do unload them. Now, it might be relative rest or relative unloading. What I mean by that is this person might need to walk around all day and you can't do anything about that. So you might get them in a shoe with a higher heel, so they're not going through as much range of motion as they're walking around. If their provoking activity is cycling or swimming or even running, I would take them off that activity so that you can reduce the peritendon irritation, treat that underlying calf capacity once you've settled it down, and then get them going again. So how I manage tendinopathy has changed substantially over the last few years. I don't use rest. I take out their provocative loads, which will be speed and compression, but you don't need to take out all load.
Y ahí una pregunta que tengo yo personal, que siempre me llamó la atención, ¿cómo tú cambias o entiendes finalmente los mecanismos de estos tendones cuando cambiamos de lugares del cuerpo? Por ejemplo, efectivamente el tendón de Aquiles con su tamaño y área de sección transversal es muy distinta al tendón rotuliano y es muy distinta al tendón del manguito rotador y es muy distinto, ¿no es cierto?, al tendón de los flexores de los dedos. Entonces, dentro de una opinión más general, ¿no es cierto?, por supuesto, entendiendo que tú tienes una experiencia específica, ¿qué condiciones finalmente son comunes a la hora de ir tratando estas patologías, considerando finalmente esta función final?
Excellent question, and this will take an hour. I will be brief.
Perdón.
So if you consider the biceps tendon is very similar to the Achilles. It's quite a long tendon. We use it as a spring. It's compressed in shoulder extension, and it has a peritendon. So they're very similar. It's like the Achilles of the upper limb. I quite like it. If you consider the rotator cuff, it's very small. There is debate about whether or not it's a spring. It's much more likely to be positional. It doesn't get thicker with pathology. That's different to the Achilles and patella, so very different. The tibialis posterior and the gluteus medius are somewhere in the middle. They don't seem to thicken with pathology. They seem to lengthen, so they're quite different again. Then in the elbow, you can use your elbow like a spring, but it's far more common that we see our low load repetition office workers with elbow pain, but they need to be managed differently to the people that have a spring activity. So to summarize that, I would consider whether or not the tendon I'm working with functions like a spring. I would then consider whether or not it has a peritendon. So for example, the patella tendon doesn't have a peritendon. The wrist and fingers have very complex peritendons. I would ask them what their provocative load is, reduce that provocative load, and then work out how to gradually expose them to the loads they need.
Bueno, es un tema fascinante dado efectivamente las distintas funciones que van cumpliendo en nuestro cuerpo y cómo para nosotros nos obliga a estar siempre considerando este contexto, ¿no?, en el cual se presenta esta patología. Ebonie, no sé si tienes tiempo para una última pregunta o ya estamos perfectos. ¿Te parece una última pregunta?
Yeah, sure. We're
Una
okay.
última. Mira, con respecto a lo que ya estuviste comentando, sabemos que tienen investigaciones en ejercicio isométrico y que estos tienen la posibilidad de reducir el dolor. Entonces, la pregunta sería, ¿cuál crees tú que es el mecanismo neurofisiológico que está permitiendo generar esta disminución de dolor a través de este tipo de ejercicio?
I wish I knew the answer to that question. That was my question in my PhD. I wanted to know the answer, you know, what caused pain in tendons or what drove nociception. And to be truthful with you, when I did the first study in isometrics and isotonics, I didn't think that there would be a difference between isometrics and isotonics. I thought we would just be warming the tendon up, which is why I compared the two contraction types. It's why I kept the same time under tension. It's why I made everything the same, because I didn't think there'd be a difference. So I was surprised to see the difference in pain. I was also surprised to see the difference in inhibition. So the inhibition is closely associated with the pain reduction, but we actually don't know the mechanism. I hope one day to find that out so I can answer that.
Esperemos que así sea, o también motivar a nuestros colegas de Latinoamérica, de Chile y Latinoamérica que nos han seguido Y agradecerte, Ebonie, por tu presentación, extremadamente útil, muy clara, y gracias por tu tiempo. Te voy a pedir que por favor no me cortes ahora, nos despedimos después internamente. Ahora nos vamos a despedir de la gente que está en YouTube, que te manda muchos saludos y mucho agradecimiento, y quiero dejarte el último espacio para dirigirte a las personas que nos están escuchando ahora en esta noche, noche americana, día australiano.
Thank you so much for joining me. Thank you for your wonderful questions. I hope one day that I can visit, and I hope that everyone stays well during this time, and I wish you the very, very best. Thank you from Australia.
Muchas gracias, Ebonie, y nos despedimos a todos. Nos despedimos después, Ebonie. Abrazo y que estén todos súper bien. Hasta luego.